I'm Dr. Gary Kupfer. I'm a member of the Division of Pediatric Hematology, Oncology at MedStar, Georgetown University Hospital. I take care of patients with all different kinds of diagnoses within the realm of pediatric hematology, oncology, both those that have cancer as well as those that do not have cancer. And in particular, I specialize in patients with bleeding and clotting disorders, as well as patients with bone marrow failure disorders, which results in aplastic anemia. When one asks me about why I do what I do, it's a complicated answer. It obviously starts with the ease, ability, and motivation to just simply engage with children, to get down on the floor and play, to feel comfortable talking to their parents. And then beyond that, the environment of academic medicine is one that really allows the opportunity for the immediate gratification of caring for children and the patient themselves, together with the intellectual pursuit of more knowledge, science, culminating in advancing therapies for the broader swath of patients. The exciting part about doing what I do is that every day I could be sitting with a patient on one hand and then walking over to my laboratory to think about the lessons learned from that patient towards advancing therapy through a particular experiment going on in my laboratory. That, at its very base, is what really is highly motivating and pleasurable in my day-to-day job. I'm really part of a group that has a really extraordinary amount of depth and breadth. For hematology oncology, one has to have that really strong toolbox of skills. Number one, I tell people and I remind people that hematology oncology is really, these are sets of diseases that really affect patients from head to toe. It's not just one isolated part of their body, and these are patients that can get quite ill. And so it really requires a true physician capable of taking care of those kinds of issues. Number two, while cancer diagnoses often attract a great deal of attention, non-cancer blood-related diseases far outnumber cancer diagnoses and are quite common out there in the community. So there's really quite a need for people to look after patients who have blood-related diseases of all different varieties. We're really more than about just simply writing the prescriptions, hanging the medications in clinic, but really place a huge emphasis on the psychosocial care of our patients with a collective team of physicians, nurses, child life experts, art therapy, social work, psychology, and psychiatry. We all have to work together to take care of patients in both the medical as well as the non-medical sense. A bleeding disorder is really exactly that. It's a disease within a patient in which there is disordered bleeding. Now, that really takes the form of two particular avenues. As I described to patients, our bodies are in equilibrium between bleeding and clotting. Within our bloodstream are a whole bunch of proteins which float around. And together with a very specialized type of blood cell called the platelet, they come together to form the clot. So when you are cutting up an onion in the kitchen, you slice your finger, you want that bleeding to stop. But you don't want that clot to grow all the way through your body, so you have to put the brakes on. So that's why it has to be a very finely tuned system. You tilt too much one way or the other, you could have too much bleeding, or indeed you could have too much clotting. Many of these diseases are alterations in that equilibrium. The causes of bleeding disorders can be both inborn or they can be what we call acquired. They can literally be alterations in our genetic makeup that demonstrate a hereditary basis for these disorders from one generation to the next. On the other hand, some of them may be acquired, where our immune systems might be tickled or perturbed in a way such as after a viral illness, or because we have autoimmune disorders, such as lupus and rheumatoid arthritis. Still others might be affected by being on the birth control pill, or becoming elderly. And so there are many both environmental or acquired factors as well as genetic factors which alter this equilibrium that I talked about. It turns out that children of all ages can develop bleeding and clotting disorders. In general, though, those types of symptoms which give us clues as to whether bleeding disorders might indeed be apparent come out in all different ways depending on age. For example, a newborn boy who's undergoing circumcision might exhibit his bleeding disorder by virtue of too much bleeding at the time of circumcision. On the other hand, a girl with a bleeding issue might not manifest her problem until she starts puberty and starts having her period. Still, other children might not show a problem until they may actually have too many bloody noses in their early childhood, in combination perhaps with allergies or some other unfortunate habits that are all too common with children, such as noses, fingers up noses. Bleeding disorders are diagnosed in a number of different ways, but perhaps the most important way is just simply listening to the patient and listening to the parent in the office and taking a very careful history as to what's going on. And it's really by doing that, getting a sense for, is there really something along the lines of a bleeding disorder going on, or is this something that's probably very low on in terms of my suspicion for there being a true problem. And it's really the compilation of answers to those questions that really formulate my suspicion. And I would say that very often we are able to kind of figure out that there is truly something going on before we even get to the blood test to nail down exactly what's going on. Once we really do have a suspicion that there may be a bleeding disorder going on, we will actually go down a path of several well-defined laboratory tests to try to narrow down exactly what is going on, ranging from a very all-encompassing type of testing that will help to hone down to exactly, in a detailed way, what the diagnosis might be, and then arrive at hopefully an answer that will then give us insight as to the best way to manage that particular disorder. Once we've arrived at a particular answer for how to, for what exactly is causing the bleeding disorder, we can then better fashion exactly how to treat it. And that really just depends on the nature of the disorder. It might be the specific lack of one of these protein factors that I mentioned that are floating around in the bloodstream. It might be the particular blood cell, the platelet, that is dysfunctional. Depending on the nature of the particular bleeding disorder, we'll actually then determine what particular medicine, medication, product, blood product that we might bring to bear to help manage that patient. So that's true on one hand. The other piece of that treatment puzzle will be what in particular is necessary to be done for a patient to manage them through a surgery or a trauma that might result in too much bleeding. For a filling, that might be something very minor in terms of treatment, like there's a particular pill that one might take to help make the blood clot more solid. On the other hand, it might be a 6-hour-long major surgery that will require the intravenous administration of specific clotting factors to help normalize a patient's ability to clot during their operation. One of my interests in the field of hematology oncology are a collection of diseases that I would term genetic predisposition diseases. Often these particular disorders take the form of some other either birth defect or a disorder in the realm of blood formation. So there's usually some kind of clue that this patient has some underlying genetic problem that brings them to medical attention. In this particular case, it's often known from experience in biology that these patients can have a predisposition or a greater chance of getting a cancer as a young person. Many of the diseases that I take care of affect the bone marrow, and thus anything that affects the bone marrow tends to have an effect also of greater chance of getting a leukemia. So as an example, I will progressively over time care for these kids, not only in their immediate needs of making sure that their levels of red blood cells, platelets, and white blood cells are adequate, but also in regular examination of the bone marrow to be sure that any subtle or very apparent changes have not occurred that make me worry that leukemia might be around the corner. In addition, some of these diseases that show up as blood-related in early childhood or even throughout childhood can often show up in other ways as young adults. For example, I still get called over to see young adult patients in the adult oncology clinic who form unusual cancers in their 20s and 30s, such as diseases and tumors of the head and neck. So in concert with my adult colleagues, it's the understanding of the genetic basis of cancer, which gives us clues to trying to preempt and provide for early detection of cancers in those patients we identify as being at risk. The relationship of blood count abnormality and cancer is definitely there. However, I try to remind patients that just because someone is anemic or has a disorder in one particular blood cell type or another is certainly not cause for alarm. Far and away, most of the time, any abnormality like that turns out to be nothing or resolves on its own. There are a whole lot of different explanations for being anemic or having a low white blood cell count that happens temporarily, such as a virus or sometimes drug. But in a small percentage of times, it can be a clue that something more sinister, more serious might be going on. Often that won't become apparent right away, but for that reason we have to follow patients along for a period of time till things become more obvious. For many of the diseases that we take care of in hematology oncology, these are lifelong disorders. They're genetic. Patients don't stop having them just because they reach a certain age or a certain threshold in their lives. For that reason, one of the biggest things we do in clinic is simply provide education. It's so critical that these kids, as they get older, acquire a knowledge of their own medical care, and frankly, that's empowering. It helps them to be their own advocate because for sure, they're going to be leaving the house, they're going to be going on to college, careers, whatnot, their own families. We want to impart upon them a basic knowledge of their own underlying medical issues because obviously they'll have to speak for themselves. This is why we're very upfront with talking to young girls about their menstruation. We want that to be a very natural thing, because sooner or later they're going to be thinking about starting a family. How do I work my way through that? They might be injured or considering a surgery as a young adult, and therefore have to consider, imparting the idea to their caregivers that I have a predisposition to getting a blood clot. You need to take care of me correctly to avoid getting a blood clot. And while legally we think about pediatrics as up to the age of 18 or even 21, we know from a biology point of view, these are diseases that are really transitioned throughout young adulthood. And for that reason, we manage and follow many of our patients all the way through their 20s, even their 30s. One of the most common things we get asked about is simply, can my kid participate in regular sports activities? The very first thing I tell people straight off the bat is that in almost all situations they can play sports. The question is, how do we manage that? And that management takes the form of a couple of different avenues. Number one, of course, we want to figure out with as much specificity as we can exactly what is the underlying problem. Because once we know that, then we can know, in the case of any kind of unexpected trauma, the best way to manage it, either with a particular medication or, in certain circumstances, do we need to restrict the level of activity going on. Above all, we really have to just have a good game plan, know what to do. In the case of my 15-year-old driving for the basket and having his legs taken out from underneath him, how are we going to react to that when he lands on his back? Are we going to have to rush him to the hospital? Or can we just worry a little bit less about it and maybe just put some ice on it and treat it as we might treat any other kind of minor trauma? It's all about knowing ahead of time, having that knowledge so then we can know the right reaction, the right level of caution. And just what we have to say no to, but more importantly, what can we say yes to? In general terms, my own level of saying yes and no really depends on the level of traumatic activity associated with a particular sporting activity. I would say no, in the case of bleeding disorder patients, to activities that what I would call purposefully violent, boxing, American-style football, where the intent obviously is to hurt the other person. In that case, I really do rule out those particular activities. I, again, stress to the families that rules in virtually every other sport. And in those cases, of all those other sports, it's really our goal together with our families and patients to come up with a good game plan. And once we have a good game plan in place, then things can proceed much more safely. When we think about going to the dentist, we know that it's a very common event for all of us, with most of us going to the dentist at least twice a year for cleanings. And in the course of doing that, all kinds of things pop up. Fillings, braces, wisdom teeth coming out, other extractions. And we know that in the case of bleeding disorders, patients bleed to varying degrees with all of those types of activities. Number one, I address the need for good oral hygiene. That means brushing a couple of times a day, flossing. I particularly point out flossing because flossing is really important for good gum health. If you can imagine, brushing does not do a very good job at removing all the food particles at the base of the teeth next to the gum. When all that food gets left behind, it creates a very rich environment for bacteria. All that bacteria results in inflammation of the gums. When tissue gets inflamed, they're more likely to bleed. And when you have a bleeding disorder, you're more likely to bleed. Put that together, and you can have some major issues going on in the mouth. Number two, we do a ton of coordination with dentists in the community. When I have a patient who I know I learned from the dentist or the patient is going for an extraction of one kind or another, we generally need to make some communication with the dentist in order to design a good plan that will result in a very safe and effective procedure. If it's a simple matter of removing a baby tooth or a little filling, well, that requires minimal intervention. In the case of wisdom teeth, however, wisdom teeth, as you may know, they have roots this long, so the amount of trauma created by their extraction is significant. It may mean I want that surgery done right here, where I can jump over and make sure that that patient has his needs addressed. Or it might simply mean that I can coordinate even more intensively with someone in the community to ensure that we have the proper medication ordered, the right follow-up care delivered. Something as simple as not having the extraction done late in the afternoon, have it done early in the day, so that if a problem does arise, we can address it much more effectively than in the middle of the night. Not have it done on a Friday, so that we're dealing with a patient during the week when clinics are open and not in emergency rooms. So just trying to put together both a medication plan, but also a common sense medical delivery plan so that these types of interventions are done safely. Heavy menstrual bleeding is a very common manifestation of a young lady with a bleeding disorder. First, though, the most important thing is to really tease out, is it truly heavy bleeding, or is it what we call disordered menstruation, or in other words, dysmenorrhea? And I actually get right down to nitty-gritty questions with my young girls who come to my office. I first apologize very respectfully. I acknowledge the fact that I'm a guy and I'm asking you all these personal questions. And that usually disarms my patients just enough that I can start getting some straight answers. But I ask, do they use pads or tampons? How many times a day are you changing? How many days does your period go on for? Is it more about the crampiness, or is it more about the bleeding that's the most problematic? And very often by teasing this out, you can gain an appreciation for it's really more about the overall symptoms of menstruation rather than the bleeding. And in that case, the treatment is often a little bit different. You're not really focusing on the bleeding, but rather the symptoms and regulation of menstruation. But of course, patients with bleeding disorders will have greater degree of menstrual bleeding. That degree of increased menstrual bleeding leads to other problems, such as iron deficiency anemia, which of course causes diminished energy, decreased thinking, more poor school performance. So all these things are interconnected. And very often we have to design a treatment plan which will help to get that bleeding under control. With respect to designing a treatment plan for a girl with heavy bleeding, one of the go-tos is actually hormone control in the form of birth control pill. And that will often make parents of an 11-year-old kind of be taken quite aback by that comment. And I really remind patients that for our patients with bleeding disorders, these are not birth control pills, these are bleeding control pills. I would say for probably 90% of our patients with bleeding disorders, all we have to do is provide hormone control in order to get their bleeding under control and thus be much more manageable and avoid all the complications of heavy bleeding.